Dear colleagues, dear ladies and gentlemen, my name is Torsten Beyna and I'm the head of the Department of Internal Medicine at the Evangelisches Krankenhaus in Düsseldorf, Germany. I'm a gastroenterologist and I'm specialized in interventional endoscopy. I'm author of the recent article in the novel Tips and Tricks section of gastrointestinal endoscopy, Barrett's ablation tips and tricks. Although endoscopic therapy of the dysplastic Barrett's esophagus and associated neoplasia has established as an effective and safe alternative therapeutic approach to surgery, there are still uncertainties among endoscopists about performance and ablation of ablation therapy in daily practice. Endoscopic resection as a first step in a hybrid treatment strategy can be performed with piecemeal endoscopic resection technique for early neoplasia without signs of submucosal invasion, and en bloc resection with endoscopic submucosal dissection in most of the cases can be used for resection of lesions with a high probability of limited submucosal invasion. Usually, ablation therapy is the second step in this multimodal treatment approach, but can also be performed as a first-line treatment in Barrett's with invisible dysplasia or neoplasia, or even non-dysplastic Barrett's esophagus in high-risk patients. Nowadays, endoscopists have a larger armamentarium of ablation techniques available. In my article, I'm going to address practical questions about pre-procedural imaging, the choice of the appropriate ablation technique, sequence of therapeutic steps, concomitant medication, and surveillance intervals. The first step of the endoscopic approach to a Barrett's esophagus with histopathologically proven dysplasia or neoplasia is always a high-quality inspection of the entire Barrett's segment to identify focal lesions. Use your best endoscope and take enough time. As a rule of thumb, reserve 1 minute for each centimeter of Barrett's length. Each visible lesion should be resected rather than being ablated using the appropriate technique, as a change or upgrading of the lesion can be expected in up to 30% of the cases after histopathological evaluation of the entire specimen. Precise report writing using validated classification systems like PRA classification for the extent of the Barrett's esophagus, or Bing classification, for example, to identify dysplasia, will help to plan your therapeutic strategy and make the findings reproducible. Radiofrequency ablation has been proven to be effective and safe for circumferential and focal ablation in numerous studies. Actual refinements of this treatment using IFA will be discussed in my article as well. Some of them have been proven to be effective and will help to simplify RFA treatment in daily routine. Others were again abandoned because of lack of efficacy or increase in complication rates in recent studies. Hybrid APC and balloon-based cryoablation are the new kids on the block for ablation therapy, but still available evidence is limited and treatment should only be done within clinical trials nowadays. In my article, I will further illustrate how ablation technique can be optimized in order to reduce complications like stricture formation or ultimately recurrence of the intestinal metaplasia, dysplasia, or Barrett's associated neoplastic disease. Periprocedural antisecretory medication is critical for an appropriate healing of the ablated segment with normal squamous epithelium. In my article, I will further elaborate on the different substances and dosage, like proton pump inhibitors, H2 antihistaminic medication, and sucralfate as well. In conclusion, I hope that my article will give endoscopists that see and treat Barrett's patients important background information to conduct effective and safe ablation therapy in daily practice. Thank you very much for your kind attention.